And then I want to get into now the branched chain amino acid supplement. Are you a fan of those?
I'm a fan if you're vegan or vegetarian. If you're
Okay,
vegan or
talk more about
vegetarian,
that.
that would be the way to utilize a branch. So the branched chain amino acids are leucine, isoleucine, and valine. They are essential amino acids that you have to get from the diet, although arguably maybe the gut microbiome, if you are a unicorn, may make that. But for the majority of people, the branched chain amino acids must come from the diet. And typically a vegan or vegetarian diet is lower protein quality, just simply meaning that it's lower in these essential amino acids. The way to kind of compensate for that, again, this compensates for the amino acid component. It doesn't necessarily compensate for the iron or the creatine or the taurine or the anserine or some of these other components, but certainly the way in which you can account for it for a protein, from a protein aspect, is by adding in a scoop of branched chain amino acids to that lower quality meal.
So can we look at that supplement as basically the other protein powders, the way in the plant-based, are taken from food one step down? Would the branched chain amino acids be an isolate almost from like a protein powder?
So it depends on where the branched chain comes from. I think some, companies, they are, comes from like silkworm or wherever. There's, I don't, not really up to date on where they're coming from.
How do you feel about the
Yeah.
association between amino acids and cancer? There's research out there talking about that.
Yeah.
And then I want you to address it from two different points. Amino acids from the diet versus supplementing, where we're going to get in a more concentrated form.
It's a really interesting question. And I think that this has been going on for a long time. And I would say before this paper that came out in 2016 in Cell, it was pretty much like put to bed, the connection between amino acids and cancer. So first of all, let's talk about cancer. So cancer is a disease of the genome. And there's initiation factors and there's promoting factors. An initiation factor of what causes cancer is a defect in the genome. That's not caused by something that you eat, right? Like you're not going to directly impact an initiation factor from an amino acid to cause cancer. So there's that. Then the next question is, what kind of cancer are we talking about? Are we talking about breast, uterine, ovarian, lung, prostate? And I think that needs to be discussed, right? So what kind of cancer are we talking about? And aside from a genetic component, what is the biggest risk factor for cancer? Do you know one of the biggest risk factors for cancers?
Oh, so many. Obesity. Environment.
You stop there. Obesity, the one thing that we could have control over, right?
Yeah.
So if we talk about
environment too, but
I mean, I don't know. I
to a point
control. Yeah. I mean, I live right outside New York City. When I lived in New York City, there's no way I could, as much as I put like air filters in, there's only so much I can do. Right. But the concept that, number one, cancer is a disease of the genome. And number two, what kind of cancers are we talking about? And number three, where is the connection? So again, and what is the risk? So one of the major risk factors of cancer, depending on what kind, is obesity. Do you know one of the other major risks of dying from cancer is?
Old age.
Cancer cachexia.
Which could be associated with old age.
So cancer cachexia is muscle wasting.
Right. I guess that's why I'm associating with old age. A lot of people as they age have less muscle on the body, but that's more directly from the cancer. Go ahead.
Exactly. So the skeletal muscle is actually what can improve survivability from cancer. Cancer cachexia, regardless of the kind of cancer, has a high probability of killing someone. So basically, how do you support muscle?
Resistance train.
And?
Eat the right foods.
Which are?
Protein.
So basically, you're telling me one of the biggest risk factors, if I'm hearing you correctly, is obesity, right? Aside from genetic. And then to help survivability, you have to protect muscle. So those are the obvious logical things. And then somehow, miraculously, there's this conversation of dietary protein and cancer. So to me, from a a geriatrician perspective, so that means I take care of, trained, fellowship trained from WashU in individuals over the age of 65, to me, it doesn't make sense, right? So sarcopenia, muscle mass, and all this other stuff. And so if we were to now go back to your original question, what's the connection between cancer and protein? And this really comes down to this one mechanistic pathway, which is mechanistic target of rapamycin. It's called mTOR, and there's mTOR1 and mTOR2, and mTOR1 is in every tissue in the body. Your brain, your pancreas, your liver, your muscle. Mechanistic target of rapamycin is exquisitely sensitive to nutrients. It's a growth promoter. It's sensitive to insulin. It's sensitive to excess calories. It's sensitive to exercise. And the sensitivity is different in every tissue, right? You with me so far? This is critical. mTOR, when chronically overstimulated, is considered a growth promoter and can be a problem if someone has cancer. If somebody already has cancer. So if someone has cancer, then growth promotion is a problem. Okay. So what do we do? So if you believe that to be true, then let's talk about the impact of mTOR on the tissues. So one of the worst things for mechanistic target of rapamycin in the space of cancer is to be chronically stimulated and overstimulated. The major way to do that is through excess calories, excess insulin, and excess carbohydrates. Liver, pancreas. When it comes to protein, mTOR is exquisitely sensitive to amino acids in skeletal muscle only. So protein stimulates mTOR primarily only in skeletal muscle. So the connection is, like if they were going to be able to prove that, then we should see some randomized controlled trials that dietary protein and its relationship to cancer, and that's never been proven. And in fact, when the information has been analyzed and we look at relative risk or risk ratio, it's never been shown to be clinically relevant, like ever.
One little thing within that I want to tease out is, isn't it true, though, if somebody was to take in an abundance of protein through gluconeogenesis, that could be converted to glucose in the system and then impact the system differently?
Great question. I would say that excess protein definitely can get converted to, and just protein in general. So protein in general gets converted to glucose, but it's much less efficient than eating straight carbohydrates. And also the impact on insulin is it's a phase 1 insulin response. So if you gave 50 grams of dietary protein and 50 grams of glucose, the insulin responses would be vastly different. But yeah, absolutely. And I think that when you have, so for every 100 grams of dietary protein, you'll convert to 60 grams of glucose through gluconeogenesis, which is a much slower process, and a way to maintain blood sugar levels without constantly eating carbohydrates.
Another little piece I want to make sure we tease out while we're in the weeds on this is the supplements of amino acids versus having that through whole foods, because obviously it's going to hit the system a lot harder if we're having that in a supplement form condensed.
Yeah.
How do you feel about that in the whole conversation around cancer?
Again, I think the question is do I feel that protein has a role in cancer? I don't. I feel that cancer is a disease of the genome. I think a risk factor is being overweight. I think a risk factor is excess calories. It's not a protein issue, right?
No, that's why it's good that you're teasing this out. You're the expert in this area, so it's good that we're getting into this because, branched chain amino acids are getting a bad rap, at least in certain circles. So it's important we hash this out.
It's unfortunate. And, you have to understand is branched chain amino acids are going to be elevated in the blood with someone who's obese, but also insulin, glucose, every substance, is going to be, these substances are all going to be elevated because it's, there's a dysregulation in the metabolism. Gluconeogenesis is not shutting down. It's if you become insulin resistant, you have excess glucose, This is not a protein problem. The only reason it becomes a protein problem is because people believe that you shouldn't be eating dietary protein. And I think the question is why. And unfortunately, I think that one would have to look at what is the agenda behind that. And I think that it can be very devastating for people's health. I think the worst piece of advice you could ever give someone who's aging is to reduce their dietary protein. It's hands down the worst piece of advice in the prime protecting years of skeletal muscle that you could ever give someone is to fast and eat low protein.
If you enjoyed that clip, press here for the full episode. I'll see you over there.
People say they don't have time. And the reality is if you don't have time for fitness, then how do you think you're going to have time for sickness? I think that we have a muscle crisis, not an obesity crisis. And that's why I do what I do. I do what I do because if you have a capacity